Uh, ovarian cancer is one of the cancers that is taking away a lot of our lives. And I'm so glad that we could have possibly the best panel to talk about this. Uh, Dr. Raina, let me begin with you. You know, to set the context, with your experience, would you like to share how has the possible outcomes of ovarian cancer evolved over time? How has the advancement led us to where we are today?
Okay, good morning, everybody. Glad to be here. Ovarian cancer is now the second commonest cancer in women apart from breast cancer. It used to be cervical cancer. Cervical cancer incidence has dropped drastically in last 20 years. So the rise in ovarian cancer has been to the extent of nearly 1% a year in the population. The second issue is the outcomes of ovarian cancer, especially stage 3, stage 4, continue to be very poor. Nearly 50% of patients who have received treatment for stage 3 and stage 4 cancer will relapse within 1.5 to 2 years. And once they relapse, the outcomes are pretty bad. Now the question that has been asked is, what has happened in ovarian cancer? Has there been any improvement? There are certain subtypes of ovarian cancer where there has been significant improvement in terms of survival and outcomes. And that is a subtype that is associated with the BRCA mutation. BRCA mutation is a genetic mutation which affects nearly 5 to 6% of women, and it is transmitted or it is acquired from the parents. And those women are prone to develop ovarian cancer. They are also prone to develop other cancers also. But fortunately, nearly 10 years ago, a drug has been discovered which overcomes the effect of the mutation of this BRCA mutation on ovarian cancer outcomes. And there is nearly 50% improvement in this subtype of ovarian cancer because they respond to a drug called as olaparib. Regarding the rest of the types of ovarian cancer, I'm afraid to disappoint you, sorry to disappoint you, there has not been much improvement in other subtypes in the last 15 or 20 years, unfortunately. Yeah. There's not been much improvement in last 10 to 15 years, except for this subtype, which is associated with BRCA mutation. So that's my answer.
Dr. Kapoor, you are involved in screening, and you have an institution that runs both pathology and imaging. Now, we are losing a lot of lives because most of the time, most cancers are not even detected in time, and ovarian cancer is getting the attention that it is. What are the challenges that you feel we are facing when it comes to diagnosis of ovarian cancer?
So, ovarian cancer in almost 80% of the cases is diagnosed at a very advanced stage because most of the patients remain asymptomatic. So, and most of the symptoms are overlapped by symptoms of other systems like the genitourinary, the gastrointestinal, and even other conditions of the gynecological system. Also, the screening methods that are available in our country in this setting, we use ultrasound transvaginally as well as the CA-125. So, these screening methods do not have high sensitivity and specificity. Talking about the CA-125, the sensitivity is lesser than 50% in early stage disease. And also CA-125 might be raised in other benign conditions like endometriosis and pelvic inflammatory pathology. It may even be normal in some types of ovarian cancer. Talking about the ultrasound TVS, it results in high false positives. Therefore, we need to devise newer biomarkers with increased sensitivity. Also, if we have to categorize the patients into high risk, apart from the family history and the risk factors, we need to do very high costly genetic testing to, as sir has already spoken about, the BRCA1, the BRCA2, and the genes associated with the Lynch syndrome. So cost is also a major issue in diagnosing ovarian cancer at an early stage.
Thank you, Dr. Akar. Dr. Gupta, you know, we know that cancers have evolved. They evolve over time, right? And so do the symptoms. What are some of the symptoms? Because the biggest challenge that I understand when it comes to ovarian cancer is because you don't have the symptoms, or you have the symptoms that people do not even understand. So what are the symptoms of ovarian cancer, and how have they evolved over a period of time?
So, over a period of time, the symptoms have remained more or less similar. There are the early stages actually don't have any symptoms. The symptoms develop very gradually, and the symptoms are non-specific and vague. So, patients sometimes have just abdominal distension. They might complain earlier in the early stages. They might just have abdominal distension, abdominal pain off and on. They might have uh, abdominal pain, or they might have indigestion and change in bowel habits, loss of appetite, and early satiety, vomiting. In late stages, they might have loss of weight and other symptoms. So these all are so vague that in the initial 1 or 2 months, they go to their family physician and generally take some tablets for digestion, Pantop, or some other syrups for indigestion. And that's how most of the times, 70% of the time, the ovary cancer is detected in stage 3 and 4. So the symptoms have remained more or less similar. However, because because of awareness now, patients do come to, many patients are coming to us in early stages also, in the very early stages, because ultrasound is done at the right time. So I think the only change I've seen that the number of patients who come in early stage have increased a little bit more because of awareness about this, that if these things are persistent, then you should go to then you should go for further investigations in ultrasound.
But has this awareness moved to beyond the metropolitan cities?
No, I would not say that. It has, because they lack the resources. They don't have a proper physician to go to when they have these symptoms. They are taking, in rural areas, they are just taking Nuska and all these things, and that's why in the rural parts we are getting late stage only. Where there is awareness and they are going to qualified doctors, then only we can pick up in early stage.
I think that's a very valid point, because it's not just the awareness of a patient, because that anyways is low, but even the people who they go to are not even aware that the patient may need some further deliberation on what needs to be done. Dr. Raina, we know that cancer treatment is known to have side effects. What have we seen with the technological development, both in terms of treatment options as well as robotics, etc.? Have we seen a reduction in side effects of the treatment of ovarian cancer?
Oh yes, this is an area of cancer.
So you might want to use the mic.
This is thanks. This is an area of cancer where there has been significant or tremendous improvement in the last 20 years. I'll just subdivide into what the problems we face during cancer treatment. One is nausea and vomiting. Nausea and vomiting used to be occurring in nearly 80% cases previously when I was a resident or a young man. That has changed drastically. There are at least a cocktail of 6 or 7 new drugs which prevent nausea and vomiting to the extent of 70 to 80% of all cancer patients. And they can be given intravenously, and they are now given as a kind of package along with chemotherapy. जब हम chemotherapy देते हैं उसके पहले we give a cocktail of 3 drugs to prevent nausea and vomiting. And the success rate of this cocktail is as I said, 70 to 80%. Some patients still get nausea, and the extent of vomiting that those patients get is much less. Mm-hmm. But overall, the improvement is to the extent of 70. That is one aspect. Other aspect is the supportive treatment like growth factors. Previously we used to give chemotherapy, the blood counts used to drop, the white cells used to drop, the red cells used to drop, the platelets used to drop. Fortunately, there are now drugs available which prevent a drop in the white cell count, as well as the platelets, as well as the RBCs. So the benefit of this is you can escalate the doses of anti-cancer drugs. Previously, you were not able to escalate the doses because the side effects would occur. There will be a drop in the white cell count. As a result, patient will get infection, septicemia, and sometimes succumb to this problem. So there has been a major development in this aspect aspect of, we call it supportive treatment, prevention of low blood counts, platelets, and RBCs, all three. The third is the supportive treatment with antibiotics. There are now newer antibiotics which are more effective and much safer because, as you know, cancer patients are immunosuppressed. They are prone to infections and they get all horrible infections. So, usme advances hue hain. The fourth is the venous access. Venous access is, every time the patients come for cancer treatment, their veins have to be poked, and some of these patients get really, very irritable and they refuse the treatment. We have developed catheters now, which are routinely used at the time of chemotherapy. These are called as chemoports as well as PICC lines, which are routinely inserted in major veins or in the subclavian vein. The benefit of this is that we don't have to poke the small veins repeatedly. The same access lines and the catheters are used for chemotherapy. So, पूरे 6 महीने जो treatment चलता है, 5-6 महीने, they don't have to be poked at other places. Only this, उसमें फिर वो prick भी नहीं लगता है, because you approach the lumen of the catheter without going through the skin. So there is no pain, there is no prick. So these are the interesting and major developments over and above chemotherapy. As I said, chemotherapy में ovarian cancer में खास advances नहीं हुए हैं, but supportive treatment in terms of the requirement for blood transfusion has gone down. Better antibiotics, better anti-nausea, anti-vomiting drugs. Unfortunately, hair loss, prevention of hair loss में खास advances नहीं हुए हैं. So these are the areas where there have been control or prevention of side effects of cancer treatment. With the result, the acceptability of cancer treatment has improved.
That's a big achievement. I mean, if we are able to raise the levels of acceptability of treatment, that's a very big achievement. Dr. Akar, one of the things that we speak of is creating access to diagnosis, And one of the options that come to mind usually in these conferences is that there has to be a population screening of the diagnosis of ovarian cancer. What do you think will be the impact or the role of population diagnosis if it were to be a reality?
So there have been multiple research clinical trials on this aspect. The most renowned of these are the UK CTOX as well as the NROS. The United Kingdom collaborative trial was one of the largest research studies in which more than 1 lakh women were screened yearly, and ultrasound was performed in these females on a yearly basis along with the serum biomarkers. So many inferences came out of this study, the first being that there was a significant shift in the staging of the disease from a late stage to an early stage diseases. That means the ovarian cancer was picked up earlier. However, this study failed to illustrate any significant improvement in the mortality rates. So even if the ovarian cancer was diagnosed early, the mortality did not improve. Also, it suggested that a screening method should apply to high-risk population. It is only cost-effective if it applies to a high-risk population. So risk factors for ovarian malignancy include family history, nulliparity, infertility, and absence of breastfeeding. Also, as we've already spoken, there are few inherited mutations of DNA repair genes like the BRCA1, BRCA2, and the genes associated with the Lynch syndrome, which have a multifold increase in risk for the ovarian cancer. For a general population, a risk will be around 1.3%, whereas if a patient inherits these genes, the risk goes up to 40 to 60%. So, for the low risk population, screening is not cost effective, and for the high risk population, screening must be done. Screening currently we use ultrasound, both transvaginally and abdominally, along with power Doppler, and we use CA125 levels. So these are used with algorithms and indices to improve the sensitivity, like the Roma indices, which takes help of HE4 protein as well as the CA125, and the RMI, which is the risk of malignancy index. So the RMI is very sensitive when used, and if the scores are more than 200, the sensitivity is as high as 100%.
Thank you, Dr. Akar. Dr. Sarika, let's come to the treatments. What have been some of the developments that we've seen when it comes to the treatment of ovarian cancer?
So as Dr. Raina said that we have recently in the last decade, we have achieved a lot in treating the genetic cancers in ovary and breast, and that is PARP inhibitors. So we can give oral treatment to patients who have these kind of genetic mutations, and we can improve their overall survival and recurrence-free survival by giving oral drugs. So, and significantly we can impact their life. So this is one thing which, and another thing is anti-angiogenic drugs are also available now, and they can be given in maintenance form so that patients can have a longer progression-free survival. Apart from that, now surgically, robot has not come up that good in ovarian cancer. However, we surgically now we are doing ultra radical surgeries easily, and we are achieving with better surgical approaches. We can achieve complete resection of the ovary tumor at a in more number of patients, and that has happened because of the ICU care, intensive care that is available in the hospitals, and with the exclusively trained doctors. So ultra radical surgeries have improved. Another thing I would say that the acceptability of surgery and the experience of surgery has improved because of better pain management in hospitals. And other than that, we are following enhanced recovery after surgery, which is where patients don't have to do a long fast. We take care of the fluid, electrolyte, counseling, education of the patient before the surgery, and then during the surgery, pain control, different kind of anesthesia, non-opioid medication, and patient can eat early now because of these enhanced recovery protocols. So the experience of surgery has improved, and I think overall experience of a cancer patient has improved in the last decade, even though we have not given a lot of improvement in overall survival in terms of months, but yeah, experience has improved and patient undergo through these procedures, surgery in a much better way.
Thank you, Dr. Gupta. Dr. Raina, this brings me to my next question to you, that would you want to elaborate more on the treatment of ovarian cancer without surgery, one? And second is, when we are talking of robotics, like ma'am said, that there has been development, but that not to that extent. Now, when I had this particular question when I was discussing about cardiology some time back, and they said that robotics hai, but the cost of the surgery does not match with the incremental benefits. So in ovarian cancer, does robotics add value, or it is just another form of surgery without incremental better outcomes?
Thanks. I think the first question you asked whether we can do without surgery in ovarian cancer. Not as of today. You have to, the nidus is in the ovary. So unless you remove the nidus of the cancer, if you do chemotherapy alone, there is a high risk of recurrence of ovarian cancer if you don't do surgery. So in advanced ovarian cancers, what is done is we debulk the tumor, reduce the size of the tumor with chemotherapy first, and then we have to operate. If you don't operate, the risk of recurrence is extremely high. So as of today, not possible not to do surgery in ovarian cancer. Second question is, what is the kind of surgery you do? The surgery generally is the conventional surgery. I'm not an expert on robotic surgery, but so robotic surgery certainly helps in reducing the morbidity of the surgery. It reduces the operating time, it reduces the bleeding and trauma to the patient, and the recovery is faster. So I think it is evolving. In some cancers it is now established. Ovarian cancer also increasing number of, especially early cases, where stage 1, stage 2 cases, robotic surgery can be easily done. But it may be difficult in advanced cases where the bulk of the tumor is large and you have to do extensive surgery. In stage 3, stage 4 cases, there could be technical problems. But it is evolving. Regarding your question about the cost and other things, I think they will come down. The cost of everything will come down. As the use of the robotic surgery increases, more people get trained in robotic surgery, the costs will come down. And they always come down in healthcare after the first 4 or 5 years.
So I have an unplanned question here, open to Dr. Raina and Dr. Sarika. You know, in talking about cost, how is the cost determined for a surgery? I mean, you know, we are, as a nation, are cheaper than the world, but we are still expensive for our own population. Now, is the cost determined basis that, you know, आप बाहर जाओगे तो इतना पैसा लगेगा, इंडिया में इतना है, ठीक है? Or can it be, or is it still higher than what the actual cost is? Is there a scope to lower the cost and make it more affordable for the Indian population?
Only marginally. I'll tell you, the cost is multifactorial. It's a hospital cost, the cost of the theater, the cost of anesthesia, the cost of keeping the hospital going, air conditioning, electrification, security of the hospital, the cost of the doctors that they charge for surgery, cost of anesthesia. So it is not one person who is involved in the costing. But I think, I won't say that the costs will come down immediately, but they will moderate in the long run. As the competition grows and the availability of more hospitals increases, cost will come down. So
I would say that, see, cost can come down with the the rent of the room. If you are taking a luxury room, that would be different. And if you are in a general room and getting the same surgery, your cost would be lesser. However, the cost is also determined by the disposable things you are using, which are providing safety to the patient. So if you are using a lot of things for the safety of the patient, then a lot of cost is needed. In the theater also, if every instrument we are using disposable so that the patient doesn't have a risk of infection and other things, then the cost increases. If the same disposable thing you're using for 10 patients, then you can reduce the cost, but at the cost of something.
the other way you can reduce the cost is increasing use of daycare. You know, in some surgeries, I'm not talking about ovarian cancer, because ovarian cancer stage 3 and 4 requires surgery and stay for at least 6-7 days. But in many other surgeries, if the surgeries can be shifted to daycare, the cost will considerably go down, and it's happening. We are doing a lot more surgeries, especially simple surgeries in daycare, and the same day the patient is discharged.
Thank you. Dr. Akar, keeping in mind the diagnostic development, how has precision diagnosis helped in curtailing the challenges of ovarian cancer?
So at present we are using CA125, as I've already discussed. It's a protein-based biomarker with low sensitivity in early stage disease. So the discovery of newer biomarkers will help guide targeted therapy, which would help reduce the risk of which will help reduce the which will help reduce the resistance to target therapies, and also minimize the unwanted side effects. This will eventually help in improving the patient outcomes and will also benefit the patients in the long run, improving their quality of lives. So one is innovating in newer biomarkers, and nowadays a lot of research is going on the nucleic acid biomarkers, which are the circular RNAs, single-stranded circular RNAs, as well as the microRNAs. So these have high sensitivity. So therefore this will eventually help in detecting ovarian cancer at a very early stage and with precision. Secondly, there is a lot of evolution that has going on in the last decade or so, in which there is advancements and shift from the laboratory-based methods to the point-of-care devices. So screening can be widely available to the masses, and also that there is increased in use of the nanoparticles, which would help in increase sensitivity in the testing methods that are being used. So this would really be a paradigm shift in the early detection of the ovarian cancers.
So my closing question is to you, Dr. Raina. Are we finding that there are more incidences of ovarian cancer today than before, or is it an outcome of more screening that is happening?
I think I'll go back to the opening talk that we had this morning. One of the issues that perhaps was not emphasized enough was the aging. Population is aging, and all cancers are related to aging. You will find that as you age, the population ages, the incidence of most of the cancers will go up. So that that cause or correlation with aging is not emphasized enough in the media. That should be emphasized. So aging you cannot stop, you cannot prevent. So aging hoti rahegi. Some cancers will continue to increase in spite of advances. The other thing that is happening is increasing detection. You know, the advancement and widespread information in the media and other sources, there is increasing diagnostic facilities available. People are going to centers for, you know, screening. So there is increasing diagnosis of ovarian cancer. But at the same time, the incidence of ovarian cancer is truly also rising by about 1% per year in the population. But the bigger rise is because of aging. The population is aging and increasing diagnosis. ये जो गलत है society में कि भाई हाहाकार हो रहा है, cancer बढ़ रहा है. Yes, some cancers are increasing, but they are being increasingly diagnosed, and population is aging. उसका कुछ नहीं कर सकते.
I think that's a very important point that you raised, that you know, एक तो detection हो रही है because there are more and more people going in for screening, and second is you know, like you said, aging. In fact, that is one big concern that we need to address as an industry, that it's okay to make a progress to help people live longer, but it's not just about adding the years, but it's also helping them age gracefully, age better, with health that can be manageable. So with that, thank you. Yes, sir.
If you take the age-related incidence of cancers, if you screen people above the age of 80 years, you know, you will find cancer in 1 in 3 people. 1 in 3 people. If you screen them, yes. Especially prostate cancer is virtually 1 in 2, 1 into 3 above the age of 80. So this is the correlation of aging with cancer. Cancer is predominantly a degeneration which occurs with aging. The person doesn't have, or the tissues don't have the ability to repair as much as they did in a younger age. So with aging, the repair mechanisms go down, the immunity goes down, the cancer comes up.
But with that happening, and with finding that, you know, more and more younger people are detected with cancers, does it also require a study on why people are aging faster and quicker? Is that
No,
something?
people are not aging faster and quicker. ये जो people are not aging fast. They are aging as they should age. But जो younger people का जो cancer incidence है, the cancer incidence, the younger people below 14, if you take,
Yep.
you know, children, cancer accounts for only 5% of cases.
Right.
If you take population below 14. So it is not so common it is common because it is so traumatic.
Right.
If you diagnose cancer, and it makes big news. But only 5% of patients below the age of 14 get cancer. So it's not that common. Commonest incidence of cancer is after the age of 50. And it rises like this.
Well, with that, we come to an end for this panel. I'm sure you would have found this valuable. Thank you so much, Dr. Raina, Dr. Akar, and Dr. Gupta, for taking our time to be with us today.
Thank you.
Thank you.
Thank you.